Hello to all my dear students. So let's start with lacrimal drainage system. It's a small and a crisp topic, but questions are definitely asked from this also. So let's see what all we need to learn. We'll start by what is lacrimal drainage system. So let's make a diagram, anatomy. It consists of, all of you please draw along. So this is the upper lid and lower lid. Again, a simplified diagram in my style, makes life easy. So this is your, starts with two puncta, right? So what are the two puncta? Lower puncta and upper puncta. Now this lower and upper puncta is going to, first there is the canaliculi, there is a vertical part of the canaliculi, correct? And then from there is a horizontal part of the canaliculi. So this is what is called ampulla. This is your canaliculi, upper canaliculi and lower canaliculi, which is going to join as common canaliculi. And this common canaliculi, this is the common canaliculi, is opening where? We all know it is lacrimal sac, and from the lacrimal sac to nasolacrimal duct. Nasolacrimal duct, NLD, opens where? So this is your first question from anatomy. It opens in the inferior meatus of nose. Okay, we'll go back to the punctum, a few points here. So when you say punctum, it is actually at the junction of your 1/6 is a part without the eyelashes. This is this part of the lid, right? This is what is called pars lacrimalis, and the 5/6 part, that is pars ciliaris, where the eyelashes are there, okay? So this whole part is pars ciliaris. And this part is your lacrimalis, pars lacrimalis. So at the junction are the two puncta, okay? So we'll remember this, easy. Then from there I said ampulla, which is around 2 millimeters. If you want to learn, nobody has asked the length of ampulla anyway. Then upper canaliculi, lower canaliculi, and then going to common canaliculi. This becomes your sac and nasolacrimal duct. Now what is the next question they have asked you? Once you are clear with the anatomy, the next question they have asked you is about your where in inferior meatus. So once we started answering, okay, NLD opens in the inferior meatus, they have started asking you where, anteriorly, posteriorly. So anatomy should be absolutely clear. We are going to answer anteriorly. So the length, if they have asked you, it is nasolacrimal duct. What is the length? Let us answer 17 to 18 millimeter. We'll answer, it can vary from 12 to 18, but we'll answer 17 to 18. Let us pick up that. Another question, right? When you're closing your eyes, what is the alignment of upper and lower puncta? This is what they ask. So on closing the eyes, what is the alignment of upper and lower puncta? We will answer upper puncta is medial to lower puncta. It is medial to lower puncta. Okay. Then we have to know about two valves. One is valve of Rosenmuller. So this valve of Rosenmuller is present between the CC, that is common canaliculi, and the lacrimal sac. So let's write here valve of Rosenmuller. Another valve that we will learn here is, this one is very important, valve of Hassner, which is opening, that means at the NLD, when it is opening into the inferior meatus, just before that is valve of Hassner. Done? So that was about your anatomy of the lacrimal drainage system. So once we know about the anatomy, comes physiology. Give the heading physiology. What you want to know here is how the tear is drained. So everybody knows that the tear is formed from the lacrimal gland and the tear, an accessory lacrimal gland and main lacrimal. From there, what is happening? It is lubricating your ocular surface. And after lubricating, some is evaporated and some is drained. Majority, of course, is draining also. So drainage system, how is it going into the canaliculi, number one? And then how is it going down into the NLD? So let's understand that. What is taking part in this is most important role is of blinking. What is So what this blinking is doing here? So what is happening is that, let's see the slide. Okay, a quick look at the anatomy and then I'm going to continue with the physiology. So here I think everything is clear here. This is a lacrimal gland. Tears, they are forming the upper and lower meniscus. Correct? It is going into the superior and inferior canaliculus and then lacrimal sac, nasolacrimal duct. Now, if you talk about the lacrimal gland, main lacrimal gland has two parts. This one is your orbital part and this becomes your palpebral part. It is separated by the LPS muscle. Okay. Coming to the next one, what we have in store, of course, these are the measurements. As I said, just remember the measurement of NLD as 17 to 18. And the two valves that we are going to remember is valve of Rosenmuller and valve of Hassner. Done? Okay. So this is what I wanted to discuss here regarding physiology. So what happens when your eye is open, when the lids are open, there is a negative pressure so when your eyes are open, there is a negative pressure. And because of the expansion of the lacrimal sac and negative pressure and the capillarity force, what is happening? That the tear from the puncta will go to the canaliculus. It is reaching the lacrimal sac. Up to this is happening due to this negative pressure where the expansion of the lacrimal sac is almost like sucking the tear. Correct? And then when you close the eyes, again it pushes, it is the pump mechanism again for this lacrimal sac, but pushes the tear down into the nasolacrimal duct. So here it creates a positive pressure and here it creates a negative pressure. If you want to write, you can note that in the closed eye there is a positive pressure so that this tear is finally going into your nasolacrimal duct, and then when you open the eyes, due to the negative pressure, there is refilling of the lacrimal sac. I hope it's clear. You can note it down. Yeah. So once we know this much about lacrimal drainage system, now we have to discuss a little bit about what are the types of watering. We have been learning about types of redness. So now we can talk about types of watering. So watering is of two types. One is lacrimation. Okay? And another, what is lacrimation? More production of the tear. And this lacrimation is what is called overproduction of tear. Second type is what? Tear is formed normally, but it is difficult to drain, so there is an overflow. So that is what is called epiphora. Everybody is familiar with this term? Epiphora. So epiphora means what? Overflow. Now, when there is epiphora or overflow, what can we think as the causes, and lacrimation, what can be? So lacrimation, we all know, any disease, anti-segmental conjunctivitis, uveitis, keratitis, glaucoma. So all these are manifesting with watering, right? So that is your lacrimation. So one cause can be anterior segment disease. Correct? What else? Okay, this is an interesting term. If you want to just know this, there is one thing called paradoxical watering. This happens in dry eye. So though there is dry eye and deficiency of tear, but still the patient is complaining of watering. This is called paradoxical watering. Again, the theory that has been given, because dry eye can be due to many conditions. So it's a vast topic if we go at the PG level. But just remember this term, it can happen. It is said to be due to hypersecretion of tears. But we will not go into too much of detail in that. And I don't want to cause much confusion. Just be familiar with the term. Okay? So, whatever hypersecretion in dry eye can lead to this. Okay, this is one thing. So, these are the two causes of lacrimation. Now, coming to epiphora. So, think yourself, when will the overflow happen? Suppose the puncta is not aligned properly. So, one important cause could be, I am writing here, malposition of lacrimal puncta. That can cause overflow, common sense. So, malposition of lacrimal puncta. This is number one. Okay. What about the next? Think about something else. Okay, there will be any obstruction in the lacrimal drainage system, of course. Any blockage and obstruction in the drainage system. Now, obstruction can be either anatomical obstruction I am talking about, or sometimes everything is fine and still there is epiphora because of functional obstruction. What is functional obstruction? You can call it as the third cause. Functional obstruction means we are talking about lacrimal pump failure, isn't it? So here we are talking about lacrimal pump failure. ठीक है? Clear है सबको? Is it okay? Okay. So these can be some of the causes of, and you know, when you talk about the pump, I was talking in physiology that there is a pump mechanism where the lacrimal sac is pumping the fluid down into the NLD. So what is the muscle responsible for that lacrimal pump? You should know it is part of orbicularis muscle. You also call it Horner's muscle. Okay. So it is, so lacrimal pump, you can just note this and you should know this. It can be due to, so it is helically arranged connective tissue fibers around the lacrimal sac and the lacrimal part of the orbicularis oculi. So through, write down, lacrimal part of orbicularis oculi. Okay? So this could be, these are the two types of water. Okay. So whatever may be the, what will be the manifestation whenever there is any blockage. So now we know what is the lacrimal drainage system, how the tear is drained, we know the whole physiology, and we know what are the types of watering. Done? Now we will study that if there is any blockage, whether it is functional or it is anatomical or any malposition, so the patient will always present with two main symptoms. ED. Simple. Epiphora and discharge. Just remember, epiphora and discharge. Why discharge? Any stagnancy will lead to your infection, and infection can lead to discharge. So these two symptoms you should. And when I examine these patients, what should I be looking for and what I can get? So if you examine this patient is entering into OPD, you will see, okay, the eyes are always very watery. So the first thing you can see under the slit lamp, try to see the meniscus height of the tear film. When you look at the meniscus height of tear film, what do you see? The lower meniscus height. This lower meniscus height is more. It is increased if there is lot of epiphora. So what is the normal height? You have to know this. We have discussed in your dry eye chapter as well. It is 0.2 to 0.4 millimeters. Correct? It is 0.2 to 0.4 millimeters. But here in case of any drainage blockage, it may go up to, can be 0.6 mm. So it can be high. Now, this may be the first thing that I'll notice. Okay, there's a lot of watery eyes and the meniscus is more. The height of the meniscus is more. What else? I should start now examining and seeing the first starting from, think yourself, the lacrimal drainage system starts from puncta. So let's start thinking from there. So first we will talk about conjunctiva. There is one condition called conjunctivochalasia. Okay. So what is conjunctivochalasia? This is a loose conjunctiva which is covering, loose conjunctiva which is not attached properly to the subtendon. It covers up puncta and now the tear cannot drain. So we can start with, I have to look for that. I'll just show you the slide. Then of course puncta, lacrimal puncta. Now lacrimal puncta, what are the problems I can see in this patient? If I should check for any stenosis, right? Number one. Number two, there could be, malpositioning. Malpositioning means like suppose the patient has ectropion, the lid is turned outward. Okay, so malpositioning. Take it? Okay. Then once we are seeing this, the third thing is we should also check for caruncle. Sometimes what happens, a large caruncle is also obstructing the puncta. So examine the caruncle. And yes, one more thing in puncta, sorry, please add here, is pouting. If there is any lacrimal punctum pouting, it is a sign of canaliculitis. So now I have seen the pouting, so I am already covering the canaliculi. After that, what I will come to? Sac. So press at the sac on examination. If something regurgitates, that means there is a blockage. So I am going to go for regurgitation test. Again I am repeating. Press at the medial canthus at the sac area. If water and discharge comes out, that means there is a blockage. So that is called regurgitation test, whether it is positive or not. You have to see that. Right? So the even obstruction in NLD and sac we will be able to appreciate with this regurgitation test. So this on examination, I am getting a lot of idea whether the lid is fine or there is ectropion, what about the puncta, what about the conjunctiva, and finally what about regurgitation, what is the situation of sac and NLD. Patient कैसे present कर रहा है? How is the patient complaining? Epiphora and discharge. Now comes the investigation. So very important tests. So next heading is investigation. First investigation that you should learn with me is fluorescein disappearance test. Now what is fluorescein disappearance test? Is you are putting the fluorescein in the eye and you expect that the drainage should be such that after 5 to 10 minutes there should be no fluorescein in the eye. So this is what you are trying to see. If there is still a fluorescein in the eye, that means there is some problem with the drainage. So this is what is called fluorescein disappearance test. Okay? So what we are saying? We are saying that you are putting the fluorescein and then wait for 5 to 10 minutes, and then we do not expect any fluorescein after 10 minutes. So if this is present, that means there is some drainage problem. Okay? Next is of course simple but asked in the exam, and that is syringing. Right? So when you are doing this, it's a common procedure done in OPD and done by even first year residents do this. है ना? So syringing क्या होता है? Syringing में you are first with the punctum dilator, we want to dilate the puncta. The puncta should be normal. So you have to check there shouldn't be any pouting or sign of acute inflammation. So once you are dilating, now with a 26 gauge needle or 27 gauge needle, which should be a blunt tip needle, right? So you are going to put the needle inside, and the first thing, before I am injecting the saline, the first thing I am going to see is, once I have put the needle inside through the canaliculi, am I getting a hard stop or am I getting a soft stop? Let's have a look at a few slides, then you are going to understand. Let's see. Okay, so when you are putting this needle and it is hitting on the bone, this is the bone, this is the sac, correct? So this is a hard stop, means there is no problem in the canaliculi and no problem in the, so everything is fine in canaliculi and common canaliculi, isn't it? But if suppose I get a soft stop, in this case what is happening? Look here. So the needle is not hitting on the bone, but it is on the soft tissue only. So this is why we call it soft stop. So if it is a soft stop, now when you are hitting like this, that means there is either the problem is in common canaliculi or the problem is in canalicular level. So first of all, I am going to see what stop I can feel. Okay, let's write. So we are saying that while syringing, we can get two findings. All of you write this flowchart. This is important and this will clear your concepts. So if I am getting a hard stop or a soft stop. If I get a soft stop, that means two options. Either LC or CC is blocked, isn't it? Now, if lower canalicular is blocked, when I will inject water, from where will it regurgitate? Think yourself. See. These are the two puncta. This is the canaliculi with the common canaliculi. This is the sac and nasal. This is what it is. Now we are saying that I am injecting the fluid here and there is a blockage in the canaliculi. Do you realize it will come out from the same puncta? So here the regurgitation will be from the lower puncta itself, because I am injecting in the lower puncta only, na? So from the lower puncta itself. But if the blockage is at the canaliculi, think yourself, look at the diagram. If it is at the canaliculi level, do you realize that means when I am injecting the fluid from here on the lower puncta like this, the yellow arrow. So naturally it cannot move forward, so it can regurgitate from both sides, na? So in common canalicular obstructions, if it is a CC obstruction, what we will learn? That it will regurgitate from both puncta. Okay, so from both puncta. Easy? So this is about your soft stop that you have to keep in mind. Chalo, now we will learn about hard stop. So hard stop means, okay, there's no problem till there. So problem is in the nasolacrimal duct. So hard stop में once I am injecting the saline and there is and what do? You ask the patient, मुंह में पानी आया? If the fluid is the saline is in the mouth and the throat, it means everything is fine. So one thing is that okay, does it mean something else also? Let's see. So there can be two options. Either the saline does not reach the throat. Saline does not reach throat. If it does not reach the throat, what do you think? Block. It is NLD blockage, isn't it? Total obstruction of NLD. Clear? This is no problem. Right? And how if it is obstructed, it is not reaching the throat. Regurgitation definitely will be from both the puncta. Because so regurgitation from both puncta. Okay. Now another option is that patient says no. Saline is tasted in the throat. So saline reaches the throat, tasted in throat. So if it is tasted in the throat, now either everything is fine, it is patent. But sometimes the patient is having epiphora. It may not be easy to just say everything is fine. So what could be the other cause? If not, it could be just a punctal abnormality, isn't it? So some punctal stenosis is there because of which he is having epiphora, otherwise everything is fine. So that could be another option. Or the third option could be, okay, anatomically the water is coming in the throat, but you are having epiphora. Another cause could be lacrimal pump failure, that is functional blockage. Okay, so it could be a mild pump failure. It could be not gross, but mild pump failure may be there. Right? So these can be the possibilities. Now what next? Now, if it is a mild pump failure, we suspect that, or we suspect a partial obstruction. So if there is a hard stop, write down please, with doubt of partial obstruction or pump failure. It is then only that what is next indicated is the third test, that is Jones dye test. So please understand, Jones dye test I am not doing on day 1. I may manage by other tests. It is only when this situation happens, there is a hard stop and I am doubting all this, then I am going to go for Jones dye test. Now what is Jones dye test? Jones dye test is 1 and 2, right? 1 is your primary test. Now primary test will tell you that this watering this patient is having is either due to hypersecretion or is it an epiphora. So primary test differentiates from hypersecretion. Right? So let's first understand this, and then there is a secondary test which is only done when primary is negative. So let's understand one by one. What happens that I am putting fluorescein in the patient's cul-de-sac. Okay? And when I put after 5 minutes of putting so primary test says, keep writing please, primary test says that you are putting fluorescein in the conjunctival sac. Now once you put the fluorescein in the tear, I will say tear, you wait for 5 minutes. Now after 5 minutes, you are putting cotton which is soaked with anesthetic into the inferior turbinate. So the cotton is there below inside the nose. Now the cotton is soaked and it is in the inferior turbinate. What will happen? Either I see fluorescein in the cotton, that means everything is fine, and this patient is a case of hypersecretion. So what is the inference? This is positive. If it is positive, means everything is fine, and the inference says this is a case of hypersecretion. Correct? But suppose I did not get any fluorescein It is negative. First of all, you all should know that false negative is a very high chance in this test, because sometimes fluorescein passage, say, through the lacrimal drainage system, it has passed, but it has still not reached the inferior turbinate into the cotton. So to exclude that, sometimes with it is oropharynx is actually seen and examined through cobalt blue light to just check whether it is a negative. It is that just to counter check that it is not a false negative. But okay, if it is negative, what next? So if it is negative, then we go for secondary test. Now what do you do in the secondary test is, it's very simple, very easy. I'll repeat for you. I said I'm putting fluorescein in the eye, cotton in the nose. 5 minutes ke baad I see whether there is fluorescein in the cotton. If it is present, that means everything is fine. This patient is a case of hypersecretion. Easy? Now if it is negative, now what I do after washing all the fluorescein from the cul-de-sac, I am going to irrigate, inject the saline. So when I am doing the irrigation, what will happen? And again I am checking with the cotton in the nose there. So what I see, either I will see fluorescein stained saline coming out, or I can see only plain saline coming out, no fluorescein. I mean to say no fluorescein, only saline and no fluorescein. These can be the two options. Chalo, let's think together. If it is fluorescein stained saline, after injecting, okay, let's see the slide. Look here. See, this is test 1, where I could get the fluorescein here, green. So this is positive. But then, what happened? If there is no fluorescein, this is negative. Correct? So if it is negative, what I do? I go for second step. Jones dye 2, test 2, or secondary test. In secondary, now I am injecting saline. If the fluorescein stained saline reaches the cotton, it is positive. But if plain saline, this is negative. So what is the inference? Now this is what we'll discuss. So if fluorescein stained saline is coming, this indicates that in the stage 1, the fluorescein was filling the lacrimal sac. Okay? Has already reached the upper lacrimal passage. So fluorescein stained saline indicates that fluorescein entered the sac, isn't it? So if it has already entered the sac, it means normal upper passage, lacrimal passage is patent. So normal or patent upper lacrimal passage. And if this is patent, because the fluorescein has already entered, what inference I will make? There may be partial obstruction of nasolacrimal duct, distal to the sac. Anything before the sac is normal, but it could be inference here will be, write down partial obstruction of NLD, partial obstruction of nasolacrimal duct, distal to the sac. Am I clear now? Why? Because when the fluorescein was in the sac, it indicates what? That it was already filled in the primary test. That means it was able to fill the lacrimal sac. That is why when I am injecting, the fluorescein is coming in the saline. Now suppose it's a plain saline with no fluorescein. Think yourself, that means fluorescein could not fill the lacrimal sac, which means the problem is in upper lacrimal passage. Right? So this indicates that the fluorescein did not enter, could not, or you can say has not entered the lacrimal sac. Why I am writing? So that you can write and not get confused. So if it has not entered means what is the problem? Where is the problem? So it is problem lies in upper lacrimal passage obstruction. Now when there is an upper lacrimal passage obstruction, what could be the possibility? So the possibility could be 2. Either it is again a partial physical obstruction, right? Anything it could be. We have talked about canalicular obstruction, punctus stenosis, other problems. And or it could also be due to pump failure, right? So when there is a pump failure, again there is no expansion of the lacrimal sac and the fluorescein stain tear has not entered the sac at all. So then it could be pump failure. Okay, so if you will read 2 more times after this lecture, you are going to understand what is Jones-Rightus for sure. But details have not been asked in your exams. What has been asked is mainly you should know the terms and where it is indicated, right? Chalo. What is the next investigation I can go for is DCG. Dacryo. So we talked about fluorescein disappearance test. We talked about syringing, hard stop, soft stop. How next we can go for Jones dye test if indicated. And what is the next investigation is DCG, which stands for dacryocystography. Now what does dacryocystography means? Dacryocysto is lacrimal sac, and graphy is studying. So detailed studying of the sac is possible through DCG. Right? So what we do here is we can use a dye into the tear. We are putting a dye in the tear and we are taking the radiograph, isn't it? Now the contrast dye that we can actually inject a radio-opaque dye. This radio-opaque dye, just know the name. This or dye or contrast, let's say contrast. So the radio-opaque contrast is ethiodized oil. Okay? So you will learn ethiodized oil and you have to inject in the canaliculi. We inject in canaliculi, and after doing that we are taking the magnified images. This is what is DCG. So what happens? What is the benefit? Any stone, any tumor in the sac can easily be seen through dacryocystography. And what is the next investigation? If suppose instead of this I use a radioactive dye. If I use a radioisotope, if I am labeling the tear with a radioisotope, now this investigation is dacryoscintilography. So क्या होती है dacryoscintilography? लिखिए. So write down we are labeling the tear with a radio. So label the tear with radioactive substance. Like technetium-99, and after that you are going to follow it through the gamma counter. Correct? Okay, 2 questions here for exams. First is, this is one investigation where you are studying the flow of tear in physiological conditions. Okay? In most physiological condition. Second thing that you have to know is, this is the investigation of choice to check for lacrimal pump failure. Okay, or functional obstruction. Okay? So that is your dacryoscintilography. We also can call it nuclear lacrimal scintigraphy. So another name you can call it as nuclear lacrimal scintigraphy. Right? Okay, before we go to the slides, one last investigation, all of you, is to complete the list. CT scan. We can go for CT or MRI to have a detailed examination for the lacrimal sac pathology, mainly for lacrimal sac pathology. Or you can also study the paranasal sinuses and structures around. Okay, so these are the different investigations that we do, right? So once we know this, let's see the slides first. Okay, so looking at the slides, so this is a normal DCG where I can see this is your upper canaliculi, lower canaliculi, lacrimal sac, nasolacrimal duct. Now look here how there is distension of the sac and this is obstruction out here in the NLD. This is the distended sac, right? And this is the obstruction in the nasolacrimal duct. And when you look at the other part, can you see this black? This is the filling defect. So this is mainly lacrimal stone. What you are looking here is at the filling defect. So we can see the lacrimal pathology in quite detail here. Again, this is the same slide of the DCG where you are injecting the radiopaque contrast into the canaliculi and taking a magnified view to see the flow. Here it seems the flow is normal, it has reached down. Then we talk about, this is what is scintigraphy that we talked about. So scintigraphy, what did you talk about is, this is the normal flow and here there is a blockage, right? Same here, this is also a picture for scintigraphy. So one side, on the right side, as we can see, there is a problem here. The flow is not happening. Can you appreciate the arrow out here, right? This is okay. So, few more slides. Okay, let's also have a look at, I was talking about that malpositioning of the lacrimal puncta due to ectropion. So again, see, this is the pool of the tear which is called lacus lacrimalis. It cannot drain into the puncta because the puncta is malpositioned, right? This can also be a cause of epiphora. Another cause, large caruncle. Can you see this? Large caruncle is actually blocking the puncta. So, large caruncle. Okay. Next is your, look at this one. This is what is conjunctivochalasia. Extra fold of conjunctiva which is blocking. Let me show you another slide. Look here. So this is the loose conjunctiva which is conjunctivochalasia. Okay, have a look at this slide. This is what is fluorescein disappearance test where we expect this fluorescein to disappear in 10 minutes from the cul-de-sac. Right. So once we know this and we have an idea of different investigations, so we talked about anatomy, physiology, what are the types of watering and what are the, how to investigate and differentiate your lacrimation from epiphora, right? And what can be the causes of epiphora. Okay, so let's write a small flow chart. What can be the causes of this obstruction of lacrimal pathway? Give the heading, obstruction of lacrimal pathway. You can divide it into, classified as, there can be acquired and congenital. Okay. So when you say acquired and congenital, what can be the cause? Either it is a nasolacrimal duct obstruction because of non-canalization of NLD, we'll be writing it shortly, or it could be due to some dacryocele formation. Cystic swelling here, dacryocele formation. So this is a congenital dacryocele. These can be the two causes. Coming to the acquired. So what can be the acquired cause? Again, as I've already told you, we have already discussed this, how to think about it. Start from the conjunctiva. So one acquired cause would be conjunctivochalasia. Then we will talk about is lacrimal puncta. So puncta, obstruction of lacrimal, we are talking about obstruction. So here we will talk about lacrimal punctal stenosis. Okay, punctal stenosis. Okay. Then this punctal stenosis, it can be either primary or secondary. So what is primary and what is secondary? So when there is no punctal eversion, only stenosis, it is primary, and secondary means it is associated with punctal eversion. Not more than this, not needed. Too much details are not needed here. That could be another cause. What can be the third cause of lacrimal obstruction? Of course, we can talk about this canalicular obstruction. And very commonly, of course, is your NLD obstruction. Let's go like canaliculi. After that, write down for the sac, write down. If you want, you can even learn it like this, as I always teach you through diagram. So, first is obstruction mein, this is lacrimal punctal stenosis. Okay, we can learn like this as well. Then after this, canalicular obstruction, right? Or common canalicular obstruction can be also be there. And then in the sac, it could be dacryolithiasis. Any stone, tumor, even tumors, all these can lead to sac obstruction, or it could be a, lastly, nasolacrimal duct obstruction. Easy to learn? Yeah, so and here you can also write conjunctivochalacia. So this is some of the causes of obstruction, acquired causes of the obstruction of lacrimal passage. Anyway, I don't expect you to write that, just keep mugging up, just common sense. This is how you will know. Okay, after this we talk about whenever there is an NLD obstruction, come to this, whether we are talking about congenital or we are talking about acquired, it always leads to inflammation of lacrimal sac. And this inflammation of the lacrimal sac is what is called dacryocystitis. So the next thing they will ask you in exam are a few facts about dacryocystitis. Give the next heading, dacryocystitis. So write down, dacryocystitis is inflammation of lacrimal sac. Write down, it is inflammation of lacrimal sac. Classification. So let's divide it as congenital or acquired. And acquired is further divided as acute and chronic. Acute and chronic. Okay, one by one. First we take congenital dacryocystitis. What will be the cause of congenital dacryocystitis? NLD obstruction is happening due to non-canalization of nasolacrimal duct. And this happens just above the valve of Hasner. Okay, so this is non-canalization of nasolacrimal duct. It is in the region of, rather you should say, region of valve of Hasner is more common. Non-canalization, sorry. So write down non-canalization. So everybody should know this, that during embryonic development, the nasolacrimal duct actually canalizes. When it fails to canalize, that is causing obstruction. So that is non-canalization of NLD. Okay, this is the main etiology. And how will this child present? So simple. Already done. Epiphora, discharge. Epiphora and discharge. So if the child comes to me with so much of epiphora and discharge, the investigation that I can go for such a small child, one which is very, very helpful is fluorescein disappearance test. Fluorescein disappearance test has got a highly specific. It is highly specific. And second I can go for is regurgitation test. This will confirm my doubt. Isn't it? And what could be the differential diagnosis of a watering in such a small child? Keep in mind, this is important at your level as well. One is your congenital glaucoma. Isn't it? But you will see other findings of glaucoma as well here. We can investigate. Or it could be just a neonatal conjunctivitis, जो हम लोग पढ़ते हैं, ophthalmia neonatorum. So this can be also a cause of watering, neonatal conjunctivitis, right? And what can be third? It could be just a punctal atresia, congenital punctal atresia. So even if you don't want to learn this, I am okay with that, but these two are very important, okay? You should know the DD of watering as an LD obstruction, congenital glaucoma and neonatal conjunctivitis. Okay? Okay, so what is the treatment? Let's make a double Q here actually. Lot of questions, repeated questions here. It will all depend on the age of your patient. If the patient is less than 9 months, I would prefer massaging. This is called Krigler's massage. Now what is Krigler's massage doing? It is actually increasing, we are massaging from the pressing on the puncta and massaging over the sac and NLD. So what we are doing is, we are increasing the hydrostatic pressure of the nasolacrimal duct. So you should all know that majority of these obstructions are membranous. Very few are bony, that will not be of course responding to this treatment, but majority are membranous, and in this increasing of hydrostatic pressure helps to open the obstruction, okay? So massaging is very helpful, but the age limit is less than 9. And if you want to write a little more information, the maximum success of this procedure, that is Krigler's massage, is seen within 6 months of age. So the success is maximum the effectiveness is maximum if the child is very small, that is within 6 months of age. But yes, for your answering of the MCQ, we take 9 months. So let's answer like 9 months only. Okay? Okay. So once we know this, we come to another thing is what after 9 months. So in more than 9 months, we can go for probing. Right? Now what is probing? So this is Bowman's probe, which is just pushed through the lacrimal drainage passage, right? So this Bowman's probe of different sizes can be used, and effectiveness is maximum, and it is seen that it will give you the success rate till 2 years, or actually 18 months. So till 18 months to 2 years of age, or maybe 2 years, you can get a lot of success. That means we may manage to open this blockage through probing. Again, it has to be a membranous blockage. A bony blockage will not open. And if nothing works, we go for surgical, but surgery is not indicated before 4 years. So more than 4 years, 4 years or more than 4 years of child, we can go for the surgery, which is DCR. What is DCR? So this is the treatment. It's important. You should know less than 9 months massaging, more than 9 months till 2 years probing is a good option. After that, we will have to wait if nothing is working. And when the child is 4 years or above, we are going to do the DCR. Now, DCR is dacryocystorhinostomy. So if this is the sac, we draw first, this is the NLD, this is the nose. So we make 2 flap of sac, cut the bone in between, then make 2 flap of nasal mucosa and join it. So dacryocystorhinostomy, joining the sac with the nose. Dacryo is lacrimal, cysto is sac. So joining the lacrimal sac with the nose. This is dacryocystorhinostomy. Now there's an exam question, guys, that where do you make the opening in DCR? So NLD is opening in inferior meatus. DCR, where are we making the opening? We are making it above, na? So answer is middle meatus. Correct? Okay. One more question they have asked you related to this. We are talking in the congenital. Then when does the tear production start? So just remember this question here. When does the tear production start? What am I talking about? So let's see. Answer is 6 weeks. So am I telling you that a newborn child is a patient of dry eye? No. We are not talking about basal tear production. That is always there. We are talking about reflex tear production. Have you realized a very small child, even if he is screaming at the top of his voice, there is no tearing, because that develops by 6 weeks onwards. Okay? So keep this in mind. Right. So these are the questions in and around. And the new modality of treating this congenital dacryocystitis could also be intubation with balloon or nasolacrimal duct with a balloon dilatation, I need to say. Okay. So another new treatment, new modality, if you want to note down, could be that we go for intubation of NLD, intubation and balloon dilatation. Either we do this balloon dilatation or not, depends on the case to case of the nasolacrimal duct. Just know this as a one line. You should just know this. Correct? So when we are talking about DCR, we will be talking about DCR in acquired also. So it comes to my mind, a DCR, keep in mind that we can do in 3 ways. Either it can be an external DCR, that means I am making the incision line below the medial canthal ligament along the lacrimal crest, right? So there will be scar seen. Okay, I don't want to do this. Go endoscopically through the nose. So endonasal DCR through the endoscopic method. Or we can go for endonasal but laser, not that is through laser DCR. So this is endonasal. Through the laser I am making the opening of the ostium, that is laser DCR. And the recent one is transcanalicular laser. That means through the transcanalicular, the laser probe is being used to make the opening in an ostium in the bone. That becomes your transcanalicular laser DCR. Okay. So I'll be showing you the slides. We'll write more around it. Just as of now, you can, if you want, you can just note it down. It can be external or endoscopically through endonasal or endonasal through laser, or it could be transcanalicular laser. Okay, right. Now, what about dacryocele? So, keep in mind that if there is amniotic fluid which has been trapped in the lacrimal sac, this happens when there is imperforate Hasner wall. Okay, so that is your congenital dacryocele. So, how will it look like? A cystic swelling which is bluish in color, right? So, bluish cystic swelling is seen. Keep in mind, a bluish cystic swelling is seen. And of course, the patient will be presenting with epiphora. So, why it is happening? I am repeating. Amniotic fluid and mucus is trapped inside the lacrimal sac. Okay, so this is the cause of congenital dacryocele. How will you manage it? Mainly conservative with antibiotics, or if needed, probing is of great help. Okay, so treatment is with either conservative with medical treatment with antibiotics, because resolution is common by itself only. Okay, just you have to manage this. So conservative treatment, or we can go for probing if needed. Generally, the resolution will happen. So keep this in mind. Next we talk about is, after this is acquired dacryocyste. How will you differentiate from an encaphalocele? That presents as a pulsating swelling. Okay. Anyway, they will not ask you at this level. This much is enough. So now next is your acquired dacryocystitis. So when you say acquired dacryocystitis, what are the points we have to know? First, we will start with acute. Very simple, all of you. What is so big about it? It's the simplest chapter. Acute dacryocystitis. How will this patient present? Epiphora discharge is always there, ED, and all signs of inflammation. Easy? So, all signs of inflammation means pain, redness, tenderness. This is what I mean. Pain, redness, tenderness. Right? So, we are going to get all this. Chalo. Uske baad, next thing is, how will you manage it? Can it lead to something? Yes. This acute inflammation may actually lead to lacrimal abscess. But we shouldn't be, or it can even cause some preseptal cellulitis. This acute inflammation can lead to, do you know preseptal? Orbital septum, which is just like a wall of the orbit. So any inflammation, we'll talk in the orbit chapter, any inflammation in front of the septum is preseptal. Behind the septum, it is called orbital cellulitis. So preseptal cellulitis or lacrimal abscess. And later, if I do any incision and drainage, which you should not do, the sequelae can be lacrimal fistula formation. So this is important. They have asked you this question, that what is the treatment of lacrimal fistula? So the fistula opens on the skin. Okay. So we have always in mind that after chronic there is a fistula. Hey? No. So after acute dacryocystitis, the sequelae can be fistula formation, especially if you try to drain the abscess and all. So whenever there is a fistula, this is a question of your exam, that what is the treatment? Don't answer fistulectomy. Okay? No. Our answer will be DCR. Correct? So we will answer DCR. So once you're making a new passage, the opening in the skin and this fistula will close by itself. Then there's another question. What is the most common etiological agent? So most common etiological agent we are going to answer is Staph aureus. Simple. Life is simple. Staph aureus. And the second you can say is Streptococcus. Streptococcus pneumoniae generally. So Streptococcus. Okay. So that was about your acute. And how will you manage it? Treatment is manage the inflammation first with conservative, with antibiotics, anti-inflammatory, right? And once you are over with this, now you can go for DCR. Then we go for dacryocystorhinostomy. Correct. Simple. Very easy. Now we come to chronic dacryocystitis. The next is chronic dacryocystitis. Let's write this and then we come to the slides. So chronic, first question, it is more common in females. Okay. Another thing is most common etiological is same that you just learned. Life is simple, Staph aureus. And how will this patient present? Again, very easy, epiphora and discharge. And you can even see a cystic swelling which is like a mucocele formation. What is the sequelae here? So this mucocele can get infected and lead to pyocele formation. And this will later lead to lacrimal fibrosis. Lacrimal fibrosis. So lacrimal fibrosis, the two walls of the lacrimal sac adhere to each other. So if the two walls adhere to each other, I cannot do DCR. How will I connect one lumen to another? So what to do? What is the treatment of fibrosis? What you do is now remove the sac itself. So DCT, which stands for, I hope you've written the Q here. DCT stands for dacryocystectomy. Okay, so this is dacryocystectomy, right? Okay, so that was about your chronic. So generally the treatment is GCR, but if it's a lacrimal fibrosis, we do DCT. Otherwise, if they ask you what is the treatment, it is DCR. Right? Okay. Now, a few lines on chronic canaliculitis. Next heading, canaliculitis. Few points that you should know at your level. Canaliculitis can be caused by Actinomyces israeli. Okay. So this is an anaerobic gram-positive bacteria, Actinomyces israeli, and another can be viral cause, that is simplex, herpes simplex virus. These are the main two causes of canaliculitis. And how will it present? Did we not learn again and again that there will be pouting of the puncta, which is hallmark of canaliculitis? Pouting of puncta. Write down, this is the hallmark feature. Okay, it's a hallmark feature. And second, of course, there can be concretions inside the canaliculi. Right? So there can be concretions inside the canaliculi. And of course, that can lead to canalicular obstruction. It may complicate as canalicular obstruction. And scarring. Obstruction and scarring. So how will you manage this? Of course, again, we generally go for conservative, right? Especially antibiotics for this bacteria. So generally it is broad spectrum antibiotics. Now apart from that, you may have to go for canaliculotomy. That means cutting through the canalicule and just curettaging the concretions. Okay. So that is called canaliculotomy. So give a linear incision and you curettage the concretions. Okay, also keep in mind, suppose you want to operate intraocularly, like for cataract, glaucoma. If you have any doubt that this patient has got a blockage in the lacrimal drainage system, there's some infection, we will not do the procedure and we will delay it. We will first manage this, otherwise that's a very high risk of infection intraocular leading to endophthalmitis, which will be, of course, a blunder. Okay, so keep this in mind. Right, so let's have a look at a few slides here and see what else we have to discuss. So few slides here. Okay, so have a look at this one. So this is your congenital dacryocystitis with a swelling and inflammation here. So this child is suffering from congenital. And this is how the child will present with epiphora and discharge. Epiphora and discharge. Can you see the discharge and a lot of watering in the eyes? Right? This one, the bluish cystic swelling, as you can see. So this is what is dacryocele, which we have been talking about. Congenital dacryocele. So this is the pouting of the puncta. So if you see, this is the punctum is not even, you can't even see the dot, that opening because of the inflammation. So this is what is pouting of the puncta. You see it in canaliculitis. What you see here is a fistula which is opening on the skin. After acute dacryocystitis. Okay, so this is the lacrimal fistula. Here again, this is the patient of acute dacryocystitis, and what you can see here is again the fistula formation. Lacrimal fistula. Look here, this is what is your mucocele, cystic swelling filled with mucus. So this is your mucocele formation. Chronic dacryocystitis, right? Yeah, so I was discussing about the external DCR and the different DCRs, a quick review here. So along the anterior lacrimal crest, we give a 10 to 15 millimeter incision like this for external DCR. I hope you all can realize that the scarring is not going to be very impressive here, right? So this is one way of doing the DCR. This is your endoscopic, where this is the exposed lacrimal bone area, middle turbinate. So we are going endoscopically. This is the endoscopic DCR. Okay, if you look here, when we see the osteums, that means the opening in the different surgeries that we are creating in the bone. So in external DCR, it has to be a large one. Then comes your endoscopic, endonasal, surgical DCR. And we have talked about what was the third one? Endoscopic, endonasal, but laser DCR. So it becomes the size of the osteum becomes smaller and smaller. Just know the different names. What I told you about these three, and the fourth I told you was transcanalicular. Which laser we use, please note down. We use diode 980 nanometer, or we can use holmium YAG laser. Generally, we are using diode 980 nanometer. And we can use it also. What was the fourth type I made you write? Was transcanalicular. Look here. So this is a transcanalicular where the laser probe is going applied through the canalicular. Transcanalicular DCR. Okay. Right. So that was all about this chapter, lacrimal drainage system. Hope you enjoyed it. Okay. And just your notes are going to be more than enough for this chapter. Don't worry about anything else. And revise your Qs and double Qs. Okay. Thank you so much. Stay blessed. Keep smiling.